Hi, everyone. Welcome back to the QueerCME Vodcast. I am super excited to have Ken with me today. Ken, do you want to introduce yourself?
Yeah, my name is Ken. I use they, he pronouns, and I've been a physical therapist for the past 8 years. I'm somebody where I've been actively transitioning for the last year. So I've been 8 months on testosterone, 2 months out from top surgery. And so trans physical therapy is something that's really important and near and dear to me.
Oh, this is very exciting. And you use he and they pronouns. And like, do you have a specific label for your identity that you feel comfortable sharing with everyone?
Yeah, so I consider myself non-binary transmasculine.
Nice. Yeah, it's so fun. I love like all the different answers I've gotten to that question. Obviously, like my interactions are more with patients on the day-to-day level, and I feel like some of the answers I've gotten have just been so fun. I think one of my favorite, I was just working with this patient the other day, and her note, like where it says like gender identity, I documented shrug and
Yes,
because she's like,
totally reasonable.
and I'm like, yes, I'm here for this situation with the gender. Well, thank you so much for sharing and sharing a little more about your personal journey as well. Yeah, and I think we're focusing at QueerCME, we're focusing on sexual health for trans patients over the next 6 months. And for me, like the primary focus on this next 6 months is like not to talk about STIs and HIV. Because I think just in healthcare in general, right? When we talk about sexual health, like automatically clinicians jump to infectious diseases. And then that's very true when we talk about LGBTQ populations because of the AIDS epidemic, which had such a huge effect on our greater community. And I don't want to minimize those things by any means, but people can get tons of education on those other places. So over the next 6 months, I really want to talk more about sexual health from a more holistic perspective, like both the components of sexual pleasure, discomfort, pain with sex, also like changes that happen with hormones, therapy for gender care and things like that. And so I really want to give clinicians an opportunity to understand more of like the larger picture of sexual health for trans and gender diverse folks. I think particularly like our het cis allies who work in our community, if they just don't have any personal exposure to like having sex in a gender diverse body or having sex with like partners on hormones or just kind of like all of the varieties and ways in which we have sex, like this will be like some just foundational exposure for them around that. Just to give you like a giant overview of what I'm doing for the next 6 months.
I love it.
But I, of course, immediately thought of you when
Thank
this
you.
topic came up in my mind because of your work in pelvic floor physical therapy. And so I guess like my first question for you would really be like, just tell like most of our listeners are referring clinicians. So just like tell us what you think we should know about pelvic floor physical therapy for trans and gender diverse folks that we don't know.
Yes. So the pelvis is something that's involved in so many intimate daily functions, be it bladder control, bowel control, sexual function, just helping support our body to move around. That pelvis is really the connector between our lower body and our upper body. And so anytime that a movement can go awry, physical therapists tend to get involved. And so I love being involved in the pelvis because, again, like, all right, sex is a movement and kind of leading to that sexual health, there can be a lot of challenges that people encounter. We tend to find that people who identify as trans femme, even if they're not on hormones yet or haven't gone through any surgeries, tend to have more pelvic pain than the general population. And so that's something that we're really curious about. We also may find, say, somebody has started testosterone and they're getting like extra growth and maybe that growth is uncomfortable. Great, that's a place where there can be interventions to address comfort. People may also be finding that they're having discomfort in their pelvic muscles. Just any point in their life, what is common is common. And sometimes we forget that when it comes to trans and gender diverse populations. And so really just, like you said, not focusing only on the big things like STDs, but focusing on wellness. And that's what I really enjoy about being a PT is I get that chance to focus on wellness and having people live happy lives versus just not having an infection.
Right. I think for so long, pelvic floor physical therapy has really, really focused on pregnancy, right? And postpartum periods. And so I think a lot of times for referring clinicians, like it gets put in that box and that's the only time they think of it. And I always like, maybe because I know a couple of pelvic floor PTs a little more closely, I've been trained well by them that everyone has a pelvis. Right. And that might not be fully true around some of the like congenital anomalies that we see, but most of our patients have pelvises, right? And so, and what Ken is saying is that the pelvis is intimately connected with any movement that we make as a person just traversing the planet. And so pelvic floor PT can be for anyone with any kind of like movement discomfort and things like that, bowel issues, constipation issues, bladder control issues, all of those things. And then really specific in like sexual health for trans and gender diverse patients, like I heard you bring up bottom growth and people on testosterone. What are some of the like interventions or strategies you use to like address that? Like I haven't heard any of these. This will be all new.
So there's kind of like Band-Aid interventions, and then there might be longer term interventions. So like a Band-Aid intervention might be, okay, can we talk about clothing? Can we talk about like tucking that? How does that fit? So there's just not immediate touch that's bothering you. Then where some people go, I have heard of some people using like over-the-counter lidocaine. Now that's something somebody should be discussing with their medical provider. Lidocaine can cause swelling in some people's tissues, and not like pleasant swelling, like unpleasant swelling. And then as far as like more longer-term intervention, it could be desensitization. So physical therapists, say you break your arm bugs you, we might use like a small vibrating tool on your arm to kind of help with that desensitization. People can play with different frequencies of vibration to see if that helps with sensitivity. And then also just kind of explaining what to expect. Like early on, changes might be kind of uncomfortable, but they should be improving with time.
Right. That's a big one. I think as a referring clinician, as a prescribing clinician, informed consent conversations like mine always include kind of sexual side effects and changes to genitals. And I go fairly detailed with this because I've had so many patients transfer care to me and like just be like, I didn't know this was going to happen. And none like thus to date, most of them have not been upset by the changes that happened, but like it would have been a better experience for them overall if they had had that counseling. And historically, we know physicians in particular, our nurse practitioner and PA colleagues are a little, I think, better at us than this when it comes to talking about sex and genitals. But physicians in particular, we get a little hung up on how to talk about it, feeling awkward or uncomfortable, or our own biases. And so, I always get consent first. Like I just say, hey, is it okay if we talk about sex stuff, or is it okay if we talk about genital stuff? Like I get explicit consent from my patient first, and then we dive into like, yes, testosterone causes clitoral enlargement, using language that the patient chooses, and that's actually one of the first things I feel like people notice on T. It's like one of the first changes. And yeah, exactly what you're saying. It can be uncomfortable, extra sensitive while that change is happening. Usually settles down after the first 6 to 9 months, right? Depending on like your dosing regimen, how quickly you escalate your dose and things like that. I also talk about how that can change the experience of orgasm for people. Have you seen that in your work? How has that come up for you?
Yeah. So I guess fortunately nobody has come to me being on testosterone saying, oh, I'm having difficulty with orgasm. But what I hear anecdotally is that many people find that how they need to orgasm changes, or what it takes to orgasm changes. Yep. And so I think being ready for that, there could be this thought like, oh, I'm starting testosterone, maybe so much more sexual, but there's still a lot of thought and deliberation that has to go into it.
Right. And so definitely I talk about that, like how we experience orgasm and what gets us off might change, right? Solely from the like standpoint of like genital experiences. And that's because I always think, I don't know how you think about this, but I always think about like there's so many nerve endings in the clitoris, and suddenly they are changing in location because things are growing and stretching. And I take care of all ages. So this is more true for like my older patients, right? Like a lot of people might have like a certain technique or tactic that has worked to get them off for many years, right? And then suddenly we are changing that course and pattern. If like clitoral stimulation was really an important part of that strategy for orgasm achievement. And so I always tell people, like, you might have to find that a new strategy. And like, this is like we're like wandering off into a random world, and this may or may not relate to some of the work you do. But you know, it's really interesting. I feel like orgasm, and I don't have the science to back this up. This is not evidence-based. Let's be very clear. This is just like the wanderings of Dr. Beal's brain. But I feel like orgasm is like really similar to like any other kind of physical experience with my body. There's like a huge muscle memory and neural pathway attachment, right? And so like for me, it's really, really hard for me to get off if I'm not like on my back, right? Like to be upright, to be standing up, to like, you know, to have to like change that like physical proprioceptive experience and like all of that, like my brain's like, wait, what the fuck? Like this is not how we usually do this. And so suddenly we're kind of doing that to your whole genitals with hormones, right? And so you just have to learn a new, I think of it as like a new neural pathway. It's like if you go to the gym and try and exercise for the first time and it's like, I can't get the form and it feels really awkward. But the next time I go, it feels like way more smooth and less awkward. Totally. I don't know. Does that make sense to you? Or was that just like a weird rambling?
No. What's really funny that I teach clients is practice how you play. And we say this whether it's soccer or whether it's sex. So it's like, yes, if you want to say there's a person that wants to orgasm in a different position, it's been really tough. It's like, okay, like put the time in, do the masturbation time, make it happen, then carry it over to partnered sex if you want to.
I love that. Can I steal this phrase? I love this wording, practice how you play. This is phenomenal. One of my partners who doesn't listen to this, so this is great. You know, so many of us like are interested in dirty talk. And then when we get in the moment, like all of the words freeze in our throat and we're like, I can't say anything, and everything I'm thinking of saying sounds really dumb. And they were like, great, for the next 6 months when I masturbate, I have to dirty talk out loud.
Oh, and so
right. Smart. I know. And they are like phenomenal at dirty talk. So I know, you know, so I love that. Practice how you play. That's it. And then like bring it into spaces with other people. That is amazing. That practice can also be with other people if that's what works for, you know, your patient and as an individual. Yeah, so definitely changes with testosterone. Are there other kind of like pelvic floor? We talked about like bottom growth, but are there other kind of pelvic floor changes we see on testosterone therapy for folks?
Ooh, so I know you were kind of saying pelvic floor PT is often so linked to childbirth, but I'm somebody I've stayed really close to the gestational realm. And so, for example, you know, if somebody's on testosterone, they might have what we would call vaginal atrophy, where there are tissue changes to that front hole that might be making it difficult for things to go in or out. And so this might come up, say, if a patient wants to do reciprocal IVF. And so while, you know, we might be talking about like pelvic pain commonly in cis females, all right, now you have a trans man coming in and the treatment may look very similar. You know, we might be talking about topical estrogen, maybe lidocaine, vaginal dilators, that kind of deal.
Nice. And I think, you know, I think we do just see like kind of general higher rates of pelvic pain among people who have been on testosterone longer term. And I don't think we always like, I don't know if you know more about like the research into that or like kind of what our leading theory as to why that is. Do you have any?
Yeah, they've done some studies where they compare people's pain rates before and after hysterectomy, and it seems like the uterus is driving a lot of that. We don't typically see the pain from uterus pop up immediately. That may develop over time. And what I tend to see is more around like 5 years on testosterone, if it's been like a consistent, maybe what we might think of like traditional trans male dosing.
Yeah. And this is, you know, not necessarily just for referring clinicians. It's not a reason to recommend someone have a hysterectomy preventively or prophylactically, right? Like whether or not someone wants to have a hysterectomy or a BLSO is really a personal choice about whether or not that feels affirming to them and their gender, and whether or not, you know, later on, maybe down the road, they are experiencing pain. We do have great studies that show no increased risk of cancer. Which used to be one of the reasons we told people historically on testosterone that they had to have histo. And so definitely lots of people, I do know lots of people who do start getting interested in exploring it when they start having more discomfort, who wouldn't necessarily have wanted surgery prior to that. Very cool. Like what other let's see. Well, we talked about changes with testosterone. Let's like explore some changes. Oh, with estrogen. I was gonna say we didn't talk about like brain changes for sex, but that's like we're talking about pelvic floor PT, so we'll skip that.
Yeah, it's all connected, right?
Yeah.
Yeah, with people who are on estrogen, sometimes there might not be the same filling of the erectile tissue, and sometimes that leads to pain for people. And so it's kind of this discussion, different ways to go about it. Does relaxation help? Does possibly focusing on other sexual activities versus activities that involve the external genitals might be meaningful. And then some people, if they are wanting to possibly have that erectile tissue totally filled up with blood, maybe making sure that's a more regular process for them if possible, so that they're not having the pain of the adhesions if all that tissue shrinks and kind of stays shrunken.
Yeah, right. And this is like in my practice, like my first question this is always one of my review system questions I ask in follow-up visits. And this is, my next question is always like, do you want to have erections or not? Like, that's like the first step for me in deciding like that treatment tree, right? Because either I'm just going to try to stop them or I'm going to start encouraging exactly what Ken's talking about, like more frequent erections. And I actually not infrequently will use like low dose daily tadalafil to support that as well, like 2.5 or 5 milligrams, if that's something someone's interested in. And so that's a really common one that I see, and definitely like similar for folks with bottom growth. If people have never had an orgasm without an erection or never had an orgasm without ejaculation, that can be a process of learning how to orgasm without those things being connected, right? Because they are all actually separate processes in the body, but so often they happen at the same time that people like not quite sure how to do one without the other initially. And so just talking about exploring different tactics for that is something I often tackle. Do you have any tips or tricks you share with people for those kinds of things?
Oh gosh. Interestingly, I tend to be more on the side of things of like addressing premature ejaculation and people who are assigned male at birth.
Yeah.
And so in those cases, we might be talking pelvic floor exercises. Oftentimes just the awareness that comes with squeezing those muscles, releasing those muscles, doesn't necessarily mean somebody to get stronger, just more aware of their pelvis. That may help. But at the same time, when we see people get more pelvic floor control, that can sometimes help with orgasm as well. So orgasm, again, definitely in the brain to a significant extent, also in the body. And so people, experiencing different types of orgasms. Sometimes there's like tension orgasm where it's like things squeeze and just sigh and release. Sometimes there's more of that rolling wave contraction. And if people are aiming for more of that rolling wave type of contraction orgasm, regardless of how they were born or what their anatomy is, then we'll often encourage, okay, like again, practice how you play. Can you squeeze those muscles? Can you release those muscles? Can you have that whole range of muscle movement so it's available to you during orgasm?
I love this. And FYI, everyone can get, like all my guests get like a little preview of questions we might go over. None of these were on that preview. So Ken, you're like rolling with me so well. Thank you. And I think like I just heard a phrase I like probably intellectually like knew, but have never heard termed before, and just like different types of orgasms. And again, I think as clinicians, particularly our like het cis allies, like endocis heteronormativity like really prioritizes sex as a biopenis going into a bio vagina, right? Like that reproductive sex is valued high over like all other forms of sex, I feel like, in our culture and in society. And I think part of that, again, endocis heteronormativity, part of it's misogyny. And so I talk about different kinds of sex all the time. I've never talked about different kinds of orgasms. I feel like my whole world just opened up a little bit more. So I love that. And I do think that's a really important point to make to our patients when they're thinking about starting hormones, is like the way in which they experience orgasm is probably going to change. And that's actually pretty expected. Yeah. Okay. Let me circle back to some of the questions we actually had so you can feel like a little more on your feet. Yeah, I think kind of what are like resources you would recommend for referring clinicians when like thinking about pelvic floor PT stuff? Are there like any kind of mini courses like where we could get a little exposure, or just like websites or blogs or videos you would say like this is like a really useful tool to take some time towards?
Yeah, as far as courses, I like MedBridge. MedBridge is based locally here in the Seattle area, and they offer different online courses. And what's kind of nice is if you pay a fee, which is pretty comparable to what you might pay for like a one-day course, you can have access to those classes for the whole year. And it could be pelvic exam techniques. So you can both get exposure to what the pelvic rehab therapist might be doing, but also possibly expand your own toolkit for examining the pelvis, both externally and internally. Because I think a lot of providers want more of those like external examination techniques, because a lot of patients just aren't comfortable. And one thing I would say in particular with trans and non-binary people is that there can be bottom dysphoria, and people don't want to have to focus on their pelvis. And so it's like, okay, like I'm going to test your functioning by having you do a bridge or a straight leg raise versus placing a finger in an orifice.
Yeah, that's awesome. So MedBridge, we can find that online. Is MedBridge only available for people who are local, or is it like online resources
All over.
Yes,
Yep.
love this.
Yeah.
Yeah, and I think you make such a great point. I again, thank you. I think I learned this from one of my certified nurse midwife colleagues. And just like techniques for doing pelvic exams, right? That don't involve using like a traditional table and stirrups. Stirrups, I know we don't call them in that footrest now, but whatever, they're still fucking stuck no matter what we call them. So, and that can be super traumatic and triggering for lots of patients. And so, definitely like what I was, taught was like having some kind of bolster to put under someone's right under their low back to lift their hips up off the table, and having them like in a butterfly leg position. Like you can still get a really thorough pelvic exam with that kind of technique. And it doesn't involve someone kind of being back in a potentially traumatic body position. And so I think tips and tricks like that for clinicians are phenomenal. Also for referring clinicians, like never, I feel like, benzodiazepines definitely have some risk associated with them in the context of like everyday use and physiologic dependence and things like that. I am never afraid to give like, a tablet though for pre-examination experiences, right? For people who have a long history of trauma and have found that helpful as well. Yeah, that's exciting. Okay, MedBridge. Is there any like, are there any podcasts you listen to or like things like that that you're like, oh, you should check this out?
I'll be honest, I'm more of like an Instagram person. So there's a good one, which is queerly.pt. So queerly.pt. And then another one I like to follow is the Vagina Rehab Doctor, all just together, Vagina Rehab Doctor. And I think both of those do a good job of covering things from a non-gendered perspective most of the time. And then also just kind of going into things that we might not expect, like, how what we eat could possibly influence some of our flora and our genitals, and how that might relate to, say, bacterial vaginosis overgrowth or that kind of deal.
I love that. I love, and then I know I've heard, I think this was Dr. Peters from OHSU maybe was talking about this. Yeah, Blair's great. And just talking about like prehab. So for people who are going to have genital gender affirming surgeries, actually getting their pelvic floor PT started pre-operatively. Right, which I think you actually helped write a series for our clinical side of things about like pre-top surgery stuff you can do. Yeah. But I think for referring clinicians, thinking again, there are lots of reasons to refer someone to pelvic floor PT that have nothing to do with surgeries. Like I want to be very clear about that. But if someone is considering a genital gender affirming surgery, talking to them about when they want to start working with pelvic floor PT, like, and a lot of times people are traveling for genital gender affirming surgery, and some surgeons have a PT they really want you to work with at some point. But like also having a local PT to like where the patient lives is, I think, a really beneficial tool. And I think for them to get to know that person before they've had a major surgery and are maybe dealing with like actual active issues from that is like a really positive way to start building that relationship. Have you been getting any of those referrals in our area? Fingers crossed.
Not so much prehab, but it does make me want to do prehab so much more for people. I tend to get more prehab for top surgery than bottom surgery. So prehab for bottom surgery, I want people to be able to do like child's pose if that's how their lower body moves, and like belly breathing into their pelvis and just any softening and relaxing. I would say the number one complication I see after vaginoplasty is just pelvic floor muscle tightness. And it's hard because people may have granulation tissue. Granulation tissue hurts like crazy. People guard even more. And so it's like pain layered on top of pain. And so if we can give people all the relaxation tools ahead of time, they can have a more comfortable experience, even if it's still going to be a tough experience.
I love those tips. And what do we think about like prehab for like metas or phalloplasties? Like, which I know is a much less common. Both are much less common than vulvovaginoplasty at this point. I recognize that, but I'm curious, like, about similar prehab approaches.
Yeah. So I'll be honest, there's no protocol on it. There's no research I've seen. And so, if it was my body that was going to go through that, some of the things that we traditionally talk about are pumping. Okay, do you have like the tissue length? Many gender affirming PTs are willing to talk about pumping technique, how to do it. Like, are you doing it right? The other thing that we consider is tissue mobility. So like on my arm, I can like pick the skin up and roll it. And sometimes people have adhesions in the tissue that's more external, labia majora and minora. And so we might want to have somebody doing some skin rolling just so that tissue is really pliable and ready to be moved around. Would probably be working on relaxation training too, if it is the type of surgery that might also say be having vaginectomy done at the same time. And then also setting expectations around bladder function and then managing constipation too.
Wow. So many things to think about. I feel like you should be writing this protocol.
Oh, thank you.
Maybe. I mean, just the like suggestion. Yeah, because that would be like a great handout or resource to have, right, for patients who like don't have access to someone like Ken, who is like this is so thoughtful about all of these things and also like very experienced, right? It can be in other areas. It can be hard to find just a pelvic floor PT in general, and then to find a pelvic floor PT who has any experience or training working with gender diverse people. Again, so much of it focuses on the pregnancy and part of different postpartum periods. Awesome. I love these ideas. Let's see, what other like tips or tricks do you have up your sleeves about pelvic floor PT for referring providers?
Oh gosh. Always feel free to refer. There are different tools for finding pelvic rehab providers because I know sometimes it's tough to track us down. The American Physical Therapy Association Academy of Pelvic Health, long name, has a provider lookup. There's also pelvicrehab.com, which is a shorter URL to remember for looking at providers. And then just saying that, there may be options too, again, in this time of COVID for virtual care as well.
Awesome. Yeah. I feel like one of my pelvic floor PTs was talking about like self-release techniques, like internal self-release techniques, with like some tool that like unfortunately is like not, I think their favorite tool for it is like not the best, like in the context of gender inclusivity, but like it might be called the Rose or something like this, and it's definitely
Intimate Rose brand, probably.
Yeah. Yes. And I'm like, okay, great. But yeah, so like things that people can potentially learn on a travel visit or virtually and then do at home for themselves.
Yeah.
Awesome. Oh my gosh. I love all the, I think we're gonna have to like write all these like resources you have down so people will be able to find them in the kind of links on the bottom of the page. What like does your website, YouTube, Instagram have like resources, things you would recommend we check out as referring providers?
There are a few, yeah. So there's a few blogs on my website, and then definitely my Instagram, and hoping to get TikTok going in this year. 2023 goals.
Yeah, right. Yes, I just yes, the TikTok. That's the thing. We were trying to do that as well. 2023 goals. So I'm there with you. Yeah, phenomenal. What else? Like, are there anything else? I feel like we've had a shorter episode today. Are there anything else you think we should bring up or review or go over?
So overlapping identities can mean even more isolation. And so one thing that I think about is, being trans or non-binary can lead to the pelvic floor maybe not being as much attention paid to it, but so can cancer treatment. And so people that maybe perhaps have had prostatectomy could benefit from physical therapy. That could again be for bladder control, pain, getting back to sexual activity, sexual rehab after prostatectomy. But also if people have had hysterectomy. And then the other thing I want to reflect on is that the surgical techniques used if somebody is having mastectomy related to cancer of the chest versus gender affirming care may be a little bit different. And so somebody could be non-binary, find out they have breast cancer and then need additional treatment. And so PTs can also be involved in some of that rehab as well.
Yeah, I think like the point of overlapping identities or intersectional identities is really, really important, and can specifically referencing that into like other healthcare conditions and diagnoses. I think like it's also so true, right, of any other like marginalized population as well. And whether that's like race, socioeconomic status, rate, all of those kinds of things, and definitely among different cultures talking about these things, like sexual health and pelvic floor PT can be very different when we're working outside of our culture of origin. And so I always encourage like clinicians, right? Like I do the populations I see in larger, larger percentages of my practice. I definitely do like culturally specific training to work with those communities. Do you have any like good resources on like pelvic floor PT and like this? Have you seen anything? I know it's like we're getting like really niche. We're asking people to do a really niche training for us right now, but have you seen anything like that?
Yeah, the short answer is no. I really appreciate Sandy Gallagher at Oregon Health Sciences University because she's spearheading a lot of the training in pelvic rehab. And even just earlier today, we were like talking about another course. So it's like things are, in the works, but it's so slow too.
Yeah, I definitely, I think it's like, right. It would be, I feel like so relevant. When I was in residency, I worked with a lot of patients who had immigrant and refugee status. And a lot of my patients had experienced genital mutilation from a young age. And so kind of their needs around like talking about sexual health, talking about sexual pleasure, talking about pain, all of those kinds of things. And then also like the rehabilitative approaches that they needed were very different as well. Because a lot of my patients had a lot of stricture because of that. So yeah, like definitely gaps in that area. If anyone wants to dive in and start the training programs, like we're here for it. We'll definitely give them a shout out. Other tips or tricks you have for us, Ken?
Oh gosh. I guess a lot of times as healthcare providers, we're dealing with information that comes up online and like, is it true? Is it not true? And so one thing that's kind of interesting is people come to me these days saying, oh, I've heard I shouldn't do pelvic floor exercises for this condition. And you may find that a lot of conditions actually will get better more with hip strengthening, belly breathing. So it used to be if somebody had a bladder issue, the medical provider might give them a one-hand page on Kegels, like, here's how you go, try it. And that approach just doesn't really work for the vast majority of people. And so I would say appreciating that if you are going to tell your clients anything for their pelvic health, maybe say, go do some hip strengthening, go do some yoga to get some down training, breathing to the pelvis, versus like jumping straight towards strengthening exercise, unless you're a provider where you've done an exam, you know that the client or patient can correctly implement doing an exercise program of the pelvis.
Yeah. So it sounds like if we're going to say like, oh, you need some pelvic floor strengthening, it might actually be detrimental to the patient if we don't really know what we're talking about.
Yeah, and just because of urinary urgency, for example, like the muscles may be kind of tight and people just don't know how to control them. And so then we're seeing leaking. I've also seen people have great muscle bulk, but still have stress urinary incontinence because their muscles are gripped like to 90% closure, 100% of the time. And so we really like, oh, if we just gave that person's muscles a break, then they would kick in automatically when we needed them to kick in.
Yeah, nice. And so again, I think there's so much more to the pelvis than like I often think of, right, as like a physician who does like more like general medicine. And so just really like always remembering that like referring is always an option, like instead of maybe giving a handout, asking if the patient would be interested in that. or if like maybe they don't have time, energy, or access to a pelvic floor PT, again, like pointing to some of these other resources, like, yes.
I want to plug a resource,
a cute
Non-Normative
handout.
Body Club. And Non-Normative Body Club, if you look that up, has a bunch of either free or donation-based exercise classes, and many of them are, donation-based. And then they include like for people of like X size or of X background. And so it can be a really great way for people to find exercise environments that aren't maybe bringing up trauma of white supremacy or of thin privilege.
Awesome. I love this. So Non-Normative Body Club is a great resource to hand out to patients. And definitely like maybe also some of the Queerly PT Instagram resources that Ken mentioned. And then I think that the biggest thing too, as like, again, as referring providers or as primary care providers, as hormone prescribing providers, right? I think one of my big roles in my patient's life is to be like a source of referrals and resources, right? So to build that network of clinicians and providers that I know that like I've worked with, that I am not worried about my patients having a non-affirming encounter with, or sometimes the reality is I know they're going to have a non-affirming encounter. And so I can prepare them for that. And I can say, look, you're in Alaska, right? The only place we can get an orchiectomy in Alaska is the men's health clinic. So already problematic. And your experience there is like the one PA who does the intakes is actually going to be pretty good with names, pronouns, and like affirming practices, but the rest of the staff is not going to be. Right. And so like, is that an experience you want to tackle? Right. Or what are the ways you can support yourself in going through that process and that experience? You will be able to access the surgery through them. They will do the surgery. They're not going to like say no by any means. But like that process might not be a deal. And so I think that is part of my role. And so getting to know your local pelvic floor PT, folks who work with trans and gender diverse patients, I think is a really great resource. Is there like a conference for y'all that's like not focused on like pregnancy?
Oh, I mean, we have combined sections meeting and it's coming up. It might be in San Diego right now, or the next week or so here. And so a lot of those topics will be pelvic health for people assigned male at birth, some gender inclusive topics. So a lot of, I am working with one school of physical therapy to try and make it not so gendered. So there's hope.
Yes. Awesome. So reaching out to your local clinicians and really building those relationships so you have places to send your patients is great. And then if you mentioned a couple of resources where people can find people, but also reaching out, on listservs or with other providers in your area, I think is super important. Other thoughts? I feel like I've been the worst interviewer today. I'm sorry. I've had like 7 cups of coffee. I maybe not the best podcaster today, but you've been lovely guest.
Oh, thank you.
Do you have any other thoughts, closing thoughts for us?
Ooh, let me think. All right. So boiling down a catchphrase, we've done practice how you play. Number 2 is what's common is common. You brought that one up, which is really helpful. And then I would say cultural humility, ask. Like, it's always okay to ask, like, are you happy with this? Some people, could be asexual. They're like, yeah, don't, you don't have to worry about my sexual functioning. I feel good. But it doesn't hurt to ask people. And I think that comes up so often in sexual health too, is like, so many providers can be like afraid to ask, but patients are just like dying or waiting for us to ask. I had somebody call the other day and they were calling for hysterectomy prehab and rehab, and they knew that was going to be an issue for them. And I was like, you know what? You're having your cervix removed. Something that concerns people when their cervix removed is their ability to orgasm. How does that sit with you? And this person was on the phone was like, oh my gosh, that's what I was actually worried about, but nobody would talk to me about it. And so sometimes when we start by leading with, are you okay if we talk about this? All right, here are some common things you might encounter. People are so relieved.
Yeah, right. I think exactly what Ken is saying is so important. Like I said, I always get explicit consent before I talk about sex or genitals with my patients. And then, and if they say no, I say, fine, we move on. Right. But if they say yes, like I get like as detailed as I can, based on like what my knowledge basis is, because I do think it is a topic that is so avoided by so many clinicians. And it's such an important part of our health and wellness. And so I love that. So practice how you play, what's common is common, and ask, I love these catchphrases. Any other catchphrases for us?
Oh gosh. Blow before you go. That's one of my favorites. And that's something that providers can be teaching. So say you have somebody who lifts weight, but they like leak when they lift weight. We'd be like, okay, like blow air out. If you hold your breath, more likely to leak urine, or in some cases even leak stool. But this doesn't just apply to weightlifters. I work with people where they leak urine when they go to stand up. Maybe they've, given birth or something recently. And so just encourage that, like, don't hold your breath when you move, like keep that air moving.
I love that. I immediately assumed it had something to do with blowjobs, but no.
Oh, okay. I have some more crass ones. Our other crass one is tits over toes. And what that does is that kind of stacks the bladder so that people are a little bit less likely to leak when they go running.
Wait, say it for us one more time. I was
Tits
laughing.
over toes.
Tits over toes. I feel like we could say like nips over toes.
Yes, let's do nips over toes.
Although not all patients end up keeping nipples when they do gender affirming breast surgery, and you absolutely do not have to. And for my surgeons who are freaked out by that, feel free to contact me. We can talk about it. I definitely was talking to a surgeon the other day, and he was like, well, if someone asked me for just one nipple, I definitely wouldn't do that. And I was like, okay. I was like, do you ask them like what their goal is or why they're interested in that, as opposed to just saying no right away, right? Like, because sometimes we find like, right, that exactly what you're saying, like ask, right? Like, what is your goal? What are you hoping to achieve from this? Because sometimes when I ask that question, what I find out is what the patient's hoping to achieve is not actually going to be achieved by the thing they're asking for. Or other times I find like they have this amazing, thoughtful like approach of like why this is important to them. And I'm like, fuck yeah, let's do that. And so to that surgeon, people are born with odd numbers of nipples all the time. It's one of the more common actual, right, supernumerary effects in development. And so I think if someone wants one nipple or three nipples, I don't necessarily know why you would be opposed to that. And some people choose not to have nipples, but nips over toes, I love. Okay. Ken, it's been phenomenal to have you. I will make sure we get all of your socials, websites, and stuff like that linked for everyone, plus some of the resources you recommended. Thank you so much.
I so appreciate getting to talk.